Good evening. Thanks everybody tonight for joining us. Just want to kind of go through quick agenda here. Not fast forwarding yet. All right, so there we go. It takes a little while to get set up. So here's our agenda tonight. Basically, we're going to kind of have a quick intro on dynaBunion. They're going to dive into SpeedButton and then talk about different ways to use this for plantar plate repairs as well as medial capsule repair. And then we'll end up with some question and answers. So basically, let me go back here. Basically, when I look at my bunion journey, which scary enough is now into the over the 20s years of doing this, when I go back and look at everything, basically the procedure that I've changed the most and changed my technique over the years for sure is bunions. And so when you look at things critically, when I go back and think about what I used to do, what I learned to do in my fellowship, I do something completely different than that now. When I look critically at things, specifically trying to correct the transverse IM angle, correcting all three planes, getting our first and second metatarsals parallel, then correcting the frontal plane with the sesamoids, and then correcting the sagittal alignment. When I go back and look at things critically, over the years, there have been times where I've hit home runs, sometimes triples, and unfortunately, sometimes much less than that. And I think the reason that we change things is certainly because of innovation, but also, I think sometimes, when you look at things, you want to look for something better and you want to look for something that's more predictable. So ultimately, one of the reasons why I kind of have been a fan of the dynaBunion is because it has helped me to get all these corrections in three different planes, basically very simply, very efficiently, and very reproducible, so that I'm feeling much better about my repairs. So, I mean, it is simple, it is stress-free, and, you want to find something, whatever you do, that's going to be predictable in your hands. But when we talk about basically getting everything in the three dimensions, there's one thing that we don't want to forget, and that is we definitely want to consider compressing. Because when you're doing the procedure, once you get all three, the three different deformities corrected, you want to be able to hold that position and then put your fixation on so that the correction that you've achieved, you leave the operating room with that correction. And that's one of the things that I really like about this system, is that it helps me to do that efficiently, simply, and reproducibly. So, one of the things that will happen is we'll talk about in a video this rack block. This is the way that we basically can help hold everything in position, in addition to getting compression, which we all know is essential to having healing at any fusion site. And as we'll show, it can either by keeping the rack block in place or using provisional fixation. And then lastly, the thing that I like about the staple compression with the nitinol is that it's not a static healing. It's basically healing that will maintain compression. So even when you're no longer in the operating room, you'll continue to get compression. And I think that is really important for getting overall healing moving forward. So when we talk about the technique, we'll talk about the 4 C's. We'll go into getting our initial cut, then getting our first correction, our second cut on the other side of the joint, and then ultimately getting our compression. And then, as we mentioned, by having this dynamic compression, we'll get continuous compression even outside of the operating room. So we'll go ahead and start our video here. So as you see, we want to make our incision really more dorsal medial. As you get used to this, you'll make your incision a little bit bigger. And as go through the learning curve, you'll make it smaller and smaller and only utilize what you need. The first thing you want to do in the first TMT is you want to go in and use your osteotome to free up the joint so that you can go ahead and put your cutting jig in completely. First, we'll put the pins on the metatarsal side, and you want to make sure you're bicortical, so you're holding in position. And then we'll go ahead and make our first cut. And you can see that the amount of bone that you're taking is very, very minimal. Then we're going to flip our jig. leave those pins in there. And this is now going to allow us to start working on getting some of our correction of our sesamoids. We'll put this jig on that goes over the second metatarsal, and then we'll start working on a rotation. And then we'll go ahead and put this pin that's going through the first metatarsal only. If you put it in the second metatarsal, you won't get the right correction that you want. And then once you have this jig in position, you can go ahead and get your desired positioning of your sesamoids. Next, you want to do the engage your windlass mechanism so that you're basically getting everything aligned properly. Then you're going to go ahead and put your pins in on the cuneiform side. And by doing the windlass mechanism, that's getting you lined up so that you're going to end up having good compression through that area. And then this is another guide. If you, for some reason, you want to take more bone, you can recut it. And once your cuts are done, again, you can see it's taking minimal bone. You can go ahead and put this hinterman on and then prepare the joint however it is that you like to. If you're a fan of bone graft, you can use that at this point as well. And once you have the joint, then you can go ahead, you have these wires in place, and you can put this thing we call the rack block on top and bring it all the way down to the bone. There's different degrees of this. This is a 0 degree, and this will help you go ahead and compress the bone in position. And then you can just see how all the wires are. You can check your alignment, make sure you're happy with everything. And then in some cases, you'll be able to put your fixation on just medial to the rack block and leave it in position. Other times you'll have to remove it because you may not have enough space. And if you end up removing the rack block, you can put some provisional fixation, one pin in through the rack block. I typically like to use the dynaBunion and use the anti-rotation bolt. And I typically use that where it's fully threaded, just so it's really helping to maintain rotation in that area. And here's an example on the left with the rack block in position, and on the right with the rack block removed with extra provisional fixation. And then lastly, here's our staple that will go in. The staple will actually go in the plate first before you put on any screws. And once you get your staple in position, then the next thing you want to do is go ahead and get this down. You may, after you put your screws in, you may have to come down and just make sure that your staple is staying in good position. And then you'll go ahead and put in the remaining screws within the plate configuration. Excuse me. I would recommend when you do this, doing non-locking. I think if you put in lockers, sometimes on one side, if you have bad bone, that's okay. But I think the reason is that if you use a non-locker, it'll allow the plate and the staple and the nitinol to do the dynamic compression, whereas if you have lockers, it'll take away some of that effect. So here's basically all the screws going in, and then lastly, what we'll do is we'll put in our anti-drift bolt, which you'll see is you don't really want it to cross your first TMT. You want it to go just outside of the joint into the base of the second metatarsal, and this will hopefully help you prevent from getting any diastasis through the Lisfranc area, and also give you some anti-rotation. And I think it is important to get bicortical purchase. One other little pearl is I do like to take down the interface between the first metatarsal and the second metatarsal base. I also like to try to achieve a fusion there if I can as well. So here's just another technique where you can do this freehand. I actually started off using this because I always used to do it freehand and I felt comfortable with that, but I've abandoned that, and now I use the system just because it's so reproducible and it's so easy. So that I definitely use the jig, and I don't use it freehand. I do use the cuts, and again, you're only really taking minimal bone. And once you do this freehand, then it's going back really to the technique that we already went through. And again, here's adding your provisional fix. All right, so let's go through a couple of cases of dynaBunion. So this is a 45-year-old female who does have a hallux valgus deformity. She also has a plantar plate tear of the second toe. And basically what we end up doing was a dynaBunion procedure. You can see there, again, the anti-bolt going into the second metatarsal. And we also did include an Aiken, which I'll include maybe 20% of the time if necessary. You know, if we're critically going to look at this, I think our IM angle looks pretty good, but we could have probably rotated our sesamoids a little bit better. And then we did a plantar plate repair, and we did do a while osteotomy with the screw kind of just off a little bit lateral so that we can put our K-wire down into position. Next case, a 52-year-old female with hallux valgus deformity, and she has painful hammer toes, the second, third, and fourth toe. So once again, utilizing the dynaBunion, in this case, no ache and osteotomy. And we did do a plantar plate repair in the second toe with a while. And then you can see the pins and the DeVries arthroplasty for the remaining hammer toe, the second, third, and fourth toes. All right, I'm going to pass this off to Dr. Briggs for his case reviews.
Thank you, everybody. Good evening on this Wednesday night. I'd just like to say a few things. Thanks to DePuy and Synthes, and also CrossRoads for having Dr. Philbin and myself kind of spread the word that and what our successes have been. I'd like to also say with Dr. Philbin, I agree wholeheartedly in his technique, and it's certainly changed my practice over the last 3 to 4 years, particularly with first-rate deformities. I struggled with 2 and 3 screw constructs for some time, and then a plate and a screw, and the evolution of this product that came about and the development of, I'm probably 80 to 90% now Lapidus with all my bunion deformities and corrections. So kudos to CrossRoads for developing this. But I'm here to talk about primarily plantar plate and the use of a SpeedButton and an anchoring system that's also helped my practice as well. Next slide. So I do not have control. You guys can go to the next slide for me. There we go. So here's a dynaBunion case. This is a mid-40s female that presents with moderate hallux valgus deformity, but you can see the diastasis between medial cuneiform base of second metatarsal. And I believe she has a plantar plate issue on this one as well. And this is what I performed. Lo and behold, a dynaBunion procedure. You can see I went a little bit long with my bolt into the third. I don't have a problem going into the third if you want even more robust stabilization across that. There's not a problem. I think it's well tolerated. What is not well tolerated is into the second or the third TMT joints. And then you can see with the little arrow, there's a little SpeedButton that's sitting on the dorsal aspect of that second toe. And you can see some mild correction associated with the MPJ now post SpeedButton. And if I were to be critical about this, I like my sesamoid positions, but I probably could have closed down my IM a little bit more. But I think she's happy and satisfied with the results. Next slide. So here's a SpeedButton. It's a atomic design. It's 1.4 millimeters or 1 by 4 millimeters. It comes with 2 sutures attached to it. And again, we're deploying this in a way that we're anchoring it into the far cortices. And I'll show you some examples of this in just a second. Next slide. So it's an extra-cortical anchoring system designed to provide secure soft tissue attachments and a button press anchor insertion. This anchor is very tiny, but it provides robust strength, upwards of I think 23 to 24 pounds of pressure or pull strength on that anchor system before it fails. So fairly robust. So the medial capsule, it's dealer's choice on this. If you want to do a little medial capsule orphy, go ahead and shave that medial eminence. You can deploy this anchor, whereby that anchor sits on the far cortices over on the lateral aspect of that first metatarsal head. And then you can imbricate or reapproximate your capsular structures on the medial side while pulling the hallux in a more rectus type position. And this is where I use it primarily with the plantar plate approach. I went to a plantar approach probably about 4 to 5 years ago as well. I was very frustrated with the dorsal approach because of lack of direct visualization, the difficulty with getting and grabbing that plantar plate. And I didn't want to do a while osteotomy all the time. There are a lot of patients that don't require a while osteotomy, in my opinion. So I went direct plantar, and I've had really nice results since then. And with the advent of the SpeedButton, it's made this primary repair much easier. And we'll go through some animation associated with that in just a second. Next slide. So again, here's what the medial capsule repair. You take the medial laminates off. You throw a wire or a drill hole from medial to lateral. You then place the SpeedButton through its hole, and then deploy the anchor on the lateral cortices, and then you can imbricate and tie down your capsule to your liking, while maintaining that the hallux is in a rectus type position, obviously. Next slide. And here it is when performing a plantar approach. I think the biggest caveat with this is you're getting over the fear that you have to go plantar to address this issue. And we'll go over some advantages and why plantar is probably maybe better indicated, or can be arguably better indicated for a repair. So it does not require a wile osteotomy. Many times we have a normal parabola and we don't want to shorten that metatarsal. And then you get exact and direct visualization of that plantar plate and the extent of the tear that's there. I also will advocate that you can also do a flexor tendon transfer through this approach. You can also repair the medial lateral capsules if needed. So it gives you direct visualization of the plantar aspect of the foot with good healing, provided that we respect the skin tension lines on the plantar aspect of the foot. Next slide. So here's a little video, hammer toe second, that you can see. We go down to the plantar aspect of the foot. And if you look at the skin lines on the plantar aspect of the foot, they're going linearly here. They go more transversely in the sulcus of the foot there. My incision is a little bit varied from this technique, but this is a very, very acceptable incision. They heal very, very well in this area. You take these dissection down full thickness, creating a whole plantar flap and the fat pad. Here's the introduction of the SpeedButton. It's from plantar to dorsal, using fluoroscopy to confirm that it's all the way to the dorsal cortices. And then you apply the atomic button with the proper code, obviously. And there you go. And your anchor's there. Then you pull on this to make sure it's strong and sturdy, and you can dial in your correction thereafter and repair your plantar plate when your toe is in a rectus position. I will say at this point, I look at where the flexor tendon is. I may then transpose that flexor tendon so it lies a little bit more centrally on that MPJ. You can also do some capsular work through this incision as well. And then it's really just skin for closure for me. Again, here's the medial capsule. We go ahead and make an L-type capsulotomy. We resect the medial eminence. We apply a wire from medial to lateral to allow for our SpeedButton. This is deployed. There are two sutures. Holding the toe in a rectus type position, we're imbricating that medial capsule and dialing in our correction that way. So just to reiterate, again, plantar approach allows direct visualization of the whole plantar plate. As many of you know, going dorsally, you can see a portion of the plantar plate. It's very difficult to appreciate the amount of attenuation and the tear that may be present. It's really straightforward dissection. It's skin, subcutaneous tissues, and then it's a large fat pad, and then you're already down to flexor tendon. Again, the osteotomy is not required. However, dealer's choice, if you want to go back up to the dorsal aspect of the foot and go ahead and perform an osteotomy, that can be done. You can do a flexor tendon transfer through the same incision while tagging the flexor tendon in with your plantar plate repair. And then certainly the ease of application and strength of the SpeedButton are all advantageous. And finally, you can dial in the amount of correction with your repair. You can see that in the previous video where you pull on that toe with your repair, and you can see your correction can be dialed in. All right, here's just a case study, I believe. Next slide. See, these are one of the more difficult feet to correct. You see that there's no bunion deformity. I didn't appreciate any hypermobility with the first ray, but it was a plantar plate tear, most likely on the lateral aspect of the joint. This is where I see it most often. The parabola is fairly normal. And here's what I did. Next slide. I went ahead, a plantar approach. You can see the little speed button that's sitting at the base of the proximal phalanx. And then I actually went ahead and performed a PIP joint fusion on this person, and likely tagged the long flexor, and I transposed it from the medial side of the joint more centrally. When that toe runs in a medial direction, that flexor tendon obviously follows suit. So we went go ahead and transpose that to the medial side of that, or to the central side of that MPJ. Next slide. Here's a case where parabola is a little bit off. There's no bunion deformity, mild medial deviation of that second digit, but very mild. Next slide. You can see that here I pinned the PIP, I repaired the plantar plate. You can see the speed button on the dorsal aspect of that second TMT. And if you compare pre and post operatively, it's a much more congruous joint. It's subtle, but it's congruous. One other caveat is when we do go plantar, when I go plantar, I tease the plantar plate off from the base of the proximal phalanx. And then once I dial in my correction with my second toe in the sagittal plane, I go ahead and advance that plantar plate with my repair to the base of that plantar aspect of the proximal phalanx. I usually take a little rongeur and nip that base of that proximal phalanx plantarly, and that gives a good plate tenodesis, so to speak. So you get a nice strong reinforcement there. A lot of times I am pinning the PIP because it does come with a hammer toe deformity, albeit I am using it for transverse plane deformities and having fairly good results with that as well. And I think this we hand off to Dr. Iyengar.
All right, thank you. So yeah, medial capsule repair for bunion. That's what I've been using the speed button mostly for. I've not gotten into the plantar plate thing, although it looks very intriguing. But this is a very simple technique, as you guys have seen. It's efficient. It's very fast to put in, especially once you get your hands on it several times and kind of get the technique. Again, it's very little risk of the anchor pulling through, as long as you make sure it engages that far cortex. Really have had no problems with that. A surgical pearl, it's just the push-pull technique, right? Once you get it across the cortices, push that red button that deploys the anchor, and then pull back on the suture, and you set it, and you're done. So as far as the next point here, when I was training, a lot of my mentors weren't using any anchor. They were just using suture to balance this, and I think the advantage of using a anchor in general is really you can tension this capsule as much or as little as you need to get the correction that you're looking for. So I think it's beneficial for that. And then I just use the same sutures to complete the rest of the capsular imbrication, and then we're done with that repair. So next slide. So this is a case we did yesterday. This was a dynaBunion correction in a youngster. And so we finished the Lapidus, and the first ray was in good alignment. I think we brought the IMA down. We got the rotation corrected, but you can still see it's tight on the lateral aspect of the first MTP joint, and it's loose on the medial. So that's where I, almost every case, am opening up the medial capsule, taking off whatever's left of the medial eminence, putting the speed button in to balance those soft tissues distally. Next slide. So this is the simple kit, right? The K-wire and the anchor, that's all that you need, and power, obviously. Next slide. So this is the, after we've applied the anchor, so you can see it resting nicely on the other side. There might be a little bit of soft tissue interposition there, but I haven't had any problems with that. Nobody's had any complaints because that, there's been any interposition of soft tissue. Next slide. And this is just completing the repair. So we've been able to reduce the first MTP joint. I'd put it into a little bit of varus because there inevitably is some bounce back, and then finish the repair using the sutures. And then here's my finished product. So still had a little interphalangeus at the end of the case, so I still did the Aiken osteotomy to ensure we had a nice straight toe. But I think we got a good correction. This was, showing the anchor bicortically and secure fixation. So this is a video that I just took yesterday. So again, you're drilling into using the K-wire to get into that medial, or to get across the head of the metatarsal. And then we take a C-arm picture. And sorry, some of this goes a little fast, and you take a C-arm picture to ensure that it is across the far side cortex. So you see that it is there. And then we pull that out and you simply apply the anchor. This is how I do it. I just unwind the whole thing, get it ready to go. I did flip this open. You may want to instruct your surgeons to keep that black cap on while they're inserting it so they don't inadvertently hit that red button and deploy it too early, because that is where you're going to get failure of the anchor if it doesn't get across the cortex. So this is this push-pull technique, right? You push it across, look at the C-arm, ensure that it's across the far side cortex, push the red button, deploy it, and then pull, and you're done. And I'm sorry, you can kind of see how it settled on that far side cortex there. And then we just finish the repair, imbricating the soft tissues. I think that's it. I don't think we need to go through the rest of it there. But yeah, that's a simple use. It's a really good anchor. I've used it pretty much exclusively for these medial capsular repairs. All right, thank you.
All right, so it looks like it's back to me. Here we go. So I just want to go over my experience of just really doing the plantar approach for plantar plate repair. First and foremost, when I look back when I was a fellow in 1999, the only time anybody was talking about plantar plate was a turf toe injury of the big toe. We knew a little bit about that at that point. We know a lot more about that now, the big toe, but nobody was really too concerned about the plantar plate at that point. And the things that I would be doing at that point for a hammer toe would be, potentially a Weil osteotomy, a condylectomy, a De Vries arthroplasty, and pinning the toe. And, one of the issues through the years that a lot of people saw using a Weil certainly was that you would get a floating toe. And there's been a lot of research, Dr. Trinka, an old Meyerson fellow, that basically looked at, some ways that we can prevent this floating toe. And I think a lot of it may have to actually do with the plantar plate itself. So back in about 2010 into 2011, what we've done for about 15 years with our fellows is we do an anatomic review. We do like a basic science course. We take, anywhere from 40 to 50 cadavers and just do a bunch of studies. We've been doing that for years. And one of the things that we did, one of our fellows did many years ago in 2010-11, is we basically looked at the plantar plate of the lesser toes just to understand the anatomy a little bit better. Guys, I'm not advancing here. Can you please help? Thank you. So we basically took, 20 cadavers. We isolated the second MTP. We dissected out the plantar plate, the origin, the insertion. And basically, as you can see here on the right, we really did a good job of skeletonizing this and just really delineating the entire plantar plate and all of its origins. Forward, please. And so we basically first looked at the footprint on the proximal origin and its indirect origin through the collaterals. And then we looked at the distal insertion into the base of the proximal phalanx. and just measured what the normal attachment was and how large it was. And as you know, a lot of times the injury is going to most commonly occur off the base of the proximal phalanx. Next slide, please. So you can see here, looking at the plantar plate, actually looking at the accessory collateral ligaments as well as the proper collateral ligaments, probably things that are not super important to our discussion today, but you can just see how we really fully dissected this out. Go to the next slide, please. And then even further looking at the orientation of the fibers of really the collateral ligaments. Next slide. So, what we know historically when it comes to toe deformity or hammer toes, there's a lot of different options. We can do an arthroplasty, we can do a fusion. Some people will use implants, some people will do flexor to extender transfers. And, when it comes to the plantar plate, again, nobody really, back when I was a fellow, really talked about it. It was not something, and a lot of people, when they came out with newer systems to start thinking about the plantar plate, people were using dorsal incisions, and the only way you could even visualize the plantar plate is you had to do a while osteotomy, whether it was indicated or not indicated. So, over time, there's been no really universally accepted technique. And then, we just kind of started to think about it more from a plantar approach. Next slide. So, the bottom line is, if you're going to fix Achilles, you don't make an incision through the anterior part of the ankle, right? You go right to where the deformity is, right where the tear is. And that was the same thing that we thought, is that, why would we address a plantar plate tear from a dorsal incision, which it's hard to see, and then you're obligated to do a wild osteotomy. So, a lot of times, being able to see it just depended on if you were going to do a fusion, an osteotomy, or what your choice was of correcting your deformity. Next slide, please. So this just showing you kind of the technique. This is an example of just a dorsal incision that you would use. Again, you don't always need to do a dorsal incision unless you're going to do a while, or unless you're going to do some other kind of a repair dorsally. Next, please. And then here's the typical incision. Some people will do a straight incision. I kind of like to do this lazy S kind of an incision. I don't know that it really matters. And in our paper that we published, the incisions were not all identical, but it didn't seem to really make a difference. So I think it's kind of dealer's choice. Next slide, please. And so one of the things that can help you to find your plantar plate and exactly where you are is that if you make a dorsal incision, or even if you don't, you can put a K-wire from top to bottom. This is really helpful if you have fellows initially, and then it can give you an idea right where your plantar plate is as you're making your incision. And a lot of times we'll put this wire and then make our incision around that, so we know exactly where we are. Next slide, please. And then here's basically exposing, going through our flexor tendons, trying to get them out of the way, and then going directly down to the plantar plate itself. Next slide. And what you'll typically find when you get in there is you'll either find that they actually have a frank tear. Sometimes an MRI can be helpful to give you this idea before you go in. Sometimes in bad cases, they may have actually some completely insufficient tissue in that area. And then sometimes it'll pull directly off the proximal phalanx. Or in other times, what you might see, like with a brostrum, where you don't really see a major tear, you just see that the ligaments are very stretched out. Then in that situation, you may actually want to take a little window of basically of the lining in this area that will allow you basically to go ahead and repair that, and then recreate the stability within the plantar plate. Next slide. So here's an example of, the typical wounds and how it looks afterwards. You can see the toes are propulsive. There's really no issue with a floating toe. That seemed to have solved a lot of that issue for me. And I think the big issue for people, whether they want to do this plantar plate or not, is they're concerned if it's going to heal, if it's going to be a painful scar. So next slide, please. So, toe surgery can be challenging. Basically, you want to do the least amount of surgery to achieve your goal. But definitely we have found that we can get improved correction and a decreased rate of recurrent deformities by including the direct plantar plate repair. Next slide. So just an article that will be published here very soon. Go to the next slide, please. And basically the gist of the article is that we had 204 plantar plate repairs performed through a direct plantar approach. 6.8% of them had superficial infections, none that required going back to the operating room for any issues. 8.3% of them had a symptomatic scar. But, you know, when we say symptomatic, it really was not terribly limiting for the patients. We can see that superficial infections were 9 times more greater if they smoked tobacco. And you can see for the 3 reoperations, they really had nothing to do with that was related to the scar. They were related to other issues. But, you know, I think at least what this data shows is if you're concerned about making the plantar incision, it's really not a major problem in any way. In fact, one of the things that's changed for me is a lot of times if I'm going to do a neuroma surgery, I'm more routinely now, me and some of my partners, we're actually making a plantar incision because the nerve's right there. And, you know, I feel more confident doing that just based on the fact of our experience with doing the plantar approach for plantar plate tears. Next slide, please. All right. Dr. Briggs, next to you.
So how often do you perform plantar plate repairs? I'm going to say I probably do on average, maybe just 1 a month. I think a strong percentage or a large percentage of these we can cure conservatively. There are small deformities, particularly mild transverse plane deformities, mild contractures. I think with taping, stiff-soled shoes, non-steroidal anti-inflammatories, they can be eradicated. Patients, as long as they don't have pain, but if the toe drifts a little bit, they tend to tolerate that. But if they've got pain and the toe drifts, then I think we need to look at that plantar plate as the culprit. So I'm probably only doing 1 a month. I probably average.
Yeah, I mean, I definitely agree. I mean, a lot of hammer toes, you know, can be treated non-operatively. You know, of the ones that end up having to have surgery, you know, they come in different forms. You know, it's not super common, but you will see people that have acute plantar plate tears. A lot of times those are going to be related to folks who have maybe had a steroid injection in the joint, or folks that, you know, had a traumatic injury. Not super common. It's more common, you know, where they have had a bunion, they have kind of a transverse lesion, and, you know, they're starting their way down to get a hammer toe. But of the people that I take to surgery, how often do I do a plantar plate repair? I would say probably 70–80% of those get a plantar plate repair. I'm often getting an MRI that will help me to look at that as well. Although, you know, on your exam, you can certainly tell if the plantar plate is stretched out. And you can also tell with, as you mentioned earlier, the weight-bearing x-rays, if they have a varus tilt or a valgus tilt, and if they're starting to develop a hammer toe.
What are the biggest challenges with plantar plate repair? I think Dr. Philbin and I alluded to earlier is that, you know, several years ago we were going dorsally with our repairs. And again, for one to appreciate and the surgeon to appreciate the plantar plate from a dorsal approach, no matter how aggressive you are with a wild osteotomy, is difficult at best. So I think going plantar has alleviated a lot of my challenges associated with repair of that plate. I echo what Dr. Philbin said earlier about repair the Achilles tendon. We make an incision over the Achilles tendon. We do a brostrum where the ligament's torn. We make an incision over the brostrum. Why are we not doing that more over the plantar plate? I advocate that. I think we're afraid to go plantar, and I will tell you, we just don't have wound complications that people certainly talk about and fear. As long as you respect the skin lines on the plantar aspect of the foot, there shouldn't be any other issues. So again, from a plantar approach, I don't have huge challenges with it. I think a transverse plane deformity is probably the hardest to correct, but that still can be done from a plantar approach fairly easily.
Yeah, for me, the biggest challenge is, I mean, when you first start doing it, is just feeling comfortable making the incision. And, you know, I think when you get your exposure, just gently retracting the flexor tendons, and there's always usually a lot of fat in that area. So I'll often use a Wheatlander retractor first. And then as I get down to the tendons, I'll use a Galpy or something of that nature to kind of help retract the fat and the flexor tendons. And then once you visualize the ligament really well, that's the challenge, just being able to visualize that really well. And once you see that and you're comfortable, you know, like you mentioned, if you need to go up to the lateral side or the medial side to look at the collaterals, you can usually see those very well. You know, if you have the fat and the tendons retracted out of your way.
What percentage of cases do you perform a while osteotomy? Again, I'm looking at that parabola, and I'm not a huge fan of these. I probably do it maybe 10% of the time. If the long second metatarsal, maybe a hypermobile first, I'll address that second in conjunction with the first ray. But again, with the direct plantar repair, I'm not doing a while osteotomy a lot of times.
Yeah, I mean, I agree. You know, I probably, I rely on the parabola, or if the joint needs to be decompressed for whatever reason. So I probably do more like 60-70% of the time, but I'm just using it, you know, I'm not doing it so I can see the plantar plate. I'm doing it so I can change the position of the metatarsal. And, you know, so that, you know, that way I'm doing it for certain pathology, not because it's a necessity.
Any key soft tissues to be aware of when making plantar incision? I think Dr. Philbin alluded to this pretty nicely. I think, you know, it's skin, and then it's a huge layer of fat, and just making sure that you're not dissecting medial or laterally through that fat, and you're keeping that nice plantar fat pad intact, and you're not disrupting that. And then just take it all the way down to the flexor. And once you identify the flexors, the plantar plate sitting right underneath that, or dorsal to that. So the only other trouble you can get into is if you're working in the interspace and you can nick a nerve, or the interdigital nerve, or the intermetatarsal nerve you can get. But again, if you're right underneath that second metatarsal with Dr. Philbin's technique, where you drill a K-wire from dorsal to plantar through that MPJ, and you know exactly where that incision's going, you just carry that incision directly down to those flexor tendons. So I think there's little else in the way there, and I think it's a fairly safe zone, provided that you respect that plantar fat pad.
Yeah, nothing else to add there.
Weight bearing protocol. I'm always trying to advance this a little bit, but I think it's proper to keep these folks probably 3 weeks off of these for 2 reasons. One, we want that skin incision to heal really nicely. And number 2, we are dealing with ligament that do have a lot of ground reactive forces that go through that. And albeit we do have a strong repair, I think 3 weeks on the early side, and some probably 4 to 5 weeks. I don't think there's anything wrong with that. And then weight bearing in a stiff-soled shoe or a cam boot, I think it's appropriate for a few more weeks. And then taping of the toe or the digit thereafter for further support.
Yeah, for me, you know, when I started doing, you know, let's say it's just a hammer toe case, or, you know, an instability case of the second or any of the lesser MTPs, initially doing the plantar approach, you know, I was very nervous about the incision, and I needed to prove to myself that it wasn't an issue. So I would typically, and initially I wouldn't weight bear them until after 3 or 4 weeks, but now, you know, I leave the sutures in until about 3 to 4 weeks, but most patients, and keep in mind, I do have a pin in, so I have a 6.2K wire. Not everybody, you know, likes to use that, but I have the pin in there just to kind of protect my repair. But I'll usually let them start weight bearing 1 week after surgery in a boot with a dressing.
Yeah, that's a great point, Dr. Philbin. I think if you have that pin across there, they're not going to put a ton of weight across that MPJ, and that's well protected.
Mm-hmm.